Good morning, everybody. Hi. Welcome to this TED Type Talk, which is a tongue twister, on this beautiful Saturday morning. My name is Piaf de Rosier, and I'm a first-year physiotherapy student at Dalhousie University, and I'm the first-year representative for the Nova Scotia Physiotherapy Association. And I'm happy to be here with you today. Okay, so as I mentioned before, this is a TED Type Talk session pertaining to how one small action can inspire a big change. We're fortunate to have 4 very accomplished speakers here with us today. In order to make the best use of our time, I'll be introducing each speaker prior to their speech, and then they'll have around 10 minutes or so to present. And then at the end of the session, I think you all have received your green feedback forms that we'll be collecting on your way out. Okay, so our first speaker for the day is Dr. Alice Aikins. She is director of the Canadian Institute of Military and Veteran Health Research. She is also an associate professor at Queen's, and she is past president of the CPA. She did her undergrad at Ottawa U, physio at Dalhousie, and master's and PhD at Queen's. She also proudly served in the Canadian Navy for 14 years. Please help me in welcoming Dr. Aikins.
Well, thank you everyone for being here this morning. There's still some seats if people want to come up front. What I'm going to talk to you about today is how a patient, so not a small incident, but a patient made an enormous difference in my career, not once, but twice. And this was a patient like any other patient. I didn't know him better than I know my other patients. We didn't end up becoming friends outside of work. But he really did have an enormous impact on my career at 2 points. So when I was in the military, I was a physiotherapist, and I got posted to Kingston in 1994 as a new grad. I met a young soldier at that time, Kevin, and he had just returned from Rwanda. And I think as physiotherapists, and we learn this through school, that mental stress, distress, or anguish can often manifest itself physically or exacerbate physical conditions. And so when Kevin came to me for treatment, we talked a lot, as you do with your patients. And he had seen some terrible things in Rwanda and was really struggling with that. This was before the time that we knew what post-traumatic stress disorder was, and we knew people were struggling, but there wasn't a name. There wasn't even the knowledge around how that could be managed. So Kevin came to me one day in early 1995, and he was really happy. And I said, "What's going on?" And he said, "I'm going to Somalia." And I said, "Oh." And he said, "Yeah, I was just in with the social worker, and he approved me to go." So I thought, wow, I'm not a mental health professional, but I don't think he's really ready to go away again. So I went into the social worker, and I said, "I don't think Kevin's ready to go on another deployment." And he said to me, "No, he thinks he is. So I think he is." And I said, "Oh, okay." In 1996, I saw Kevin again after he'd deployed to Somalia. And he was broken. Kevin was broken. Not physically. I mean, he had physical issues. And at that moment, I realized that I had not been the advocate that I should have been for my patient. And so I decided right there and then that I was never again going to see a patient that I was not going to advocate for 100%. So I advocated tirelessly for Kevin, but for all my patients. We got Kevin the help he needed. He got great treatment in the military. They have a great system. But I released from the military in 1998, and I took that with me into civilian private practice. And I never stopped advocating for my patients, whatever they needed, if it was mental health services, if it was for me to talk to their family doctor, whatever they needed, I did it. Liaising with surgeons, whatever. Because it's not about me, right? It's about the patient. And it was just a huge, huge impact on my career. And I think one of the reasons that my patients were so devoted to me, because they knew I would advocate for them. So life marches on, and in 2006, that was the first very big impact Kevin had on my career. In 2006, two things happened. I finished my PhD and became a professor at Queen's, and I ran into Kevin again, just on the street, and we were chatting, and he was with his pregnant wife and little child, and he still in the military, and he said to me, "I'm going to Afghanistan." And I said, "Wow." And he looked great. He wasn't my patient. He looked great. So time marched on again, and in 2008, things got too much for Kevin, and he took his life. And when I sat at his funeral, and I looked at his wife and children, I thought, we're not doing enough. Canada is not doing enough. And this was the second very big impact that Kevin had on my career. At that time, I'd been talking to a retired general who had been my base commander about what we could do in Kingston, Kingston being an area with the largest army base, the Royal Military College, Queen's, the hospitals, about what we could do for military and veterans and their families. We approached the then Surgeon General, who was also looking for a link with the academic community. So by this time, I'm an academic, and my thought is, we need to provide military, veterans, and their families with the best evidence to inform policies, practices, and programs that will impact their lives. In 2010, we started the Canadian Institute for Military and Veteran Health Research. 5 years on, I am so proud to say that we are a network of 37 Canadian universities, over 1,000 researchers dedicated to researching the health needs of Canadian military personnel, veterans, and their families. The federal government comes to us when they're going to make new policies. We link with health professional associations around programming and treatments. And we have very broad outreach in Canada and internationally. We link with our international counterparts who face the same thing. It has been and I'm also really proud to say that over the last, particularly 2 years, we've brought in a little over $30 million to support this research. I've built a phenomenal team, but it's been a lot of work. But every time that I think I'm getting tired or this is consuming my life, I think of Kevin, and I think of all the other Kevins I knew, and I know that it's the right thing to do. So that is how one patient really dramatically affected my life twice, my career twice, and I think of Kevin often. Thank you.
Thank you so much, Dr. Aiken. So our next speaker is Dr. Jeff Bostick. He is an assistant professor at the School of Rehabilitation at the University of Alberta. His professional and research interests are related to chronic spinal pain and the influence of cognitive processes on the patient's experience of pain. Let us please extend a warm welcome to Dr. Jeff Bostick.
Is this the slide thing over? Advancer? Okay. So thanks everyone for being here. My TED Talk today is about TED. And Ted was a physical therapist I worked with when I was early in my career. And Ted gave me some very simple advice that at the time I didn't really know how impactful it would be, but it ended up being very impactful in my career. So his advice was to me, if you listen and help people get moving, you'll help a lot of people. So to illustrate the impact this had on my career, I just would like to tell a little story about a newly graduated physiotherapist, degree in hand, ready to take on the world. Everything made sense in my head. If you have a disc herniation, I have a treatment for that. Frozen shoulder, I have a treatment for that too. But I'll never forget my first patient who had a complex shoulder problem. And I did everything you're supposed to do that I had in my books, and he didn't get better. And unfortunately, I had lots of those experiences as a new grad. And every time I had that experience, I immediately felt, I just don't know enough. Things are too complex. I need a complex solution for a complex problem. And I used to listen with envy to some of the colleagues I worked with, discuss complex theories on how different problems are affecting their patients. And I just felt like I just didn't know enough. And later on, I kind of realized that I got a bit distracted by the complexity. And I think maybe by being distracted by the complexity, I forgot about some of the simple things. So I'd like to just tell a little story. I should have advanced that. A little story that illustrates how getting overly focused on the complexity can be distracting on some of the simple things that we do so well. And so this story is a Dr. Seuss story. Seems to be a big theme at this conference. And it's called The Rabbit, the Bear, and the Zenakuu Tree. And basically the story is there's a rabbit who's about to get eaten by the bear, and the rabbit thinks quickly to try to distract the bear and starts counting the eyelashes on his face. And he says there's 10 on one eye, 9 on the other. And then the rabbit goes on to describe all the consequences of having only one eyelash. So the rabbit says to the bear, oh, a lack of an eyelash will make you a wreck. A lack of an eyelash will break a bear's neck. Who knows what might happen? You may fall apart. Be careful, poor bear. Don't even cough, or your feet and your tail and your nose may fall off. And so I was the bear. I was distracted by the musings of my rabbit colleagues, and I forgot about some of the basics that make physios so wonderful. So I have 3 points that I would like to cover today related to Ted's advice, that if you listen to people and help them get moving, you're going to help a lot of people. And so the first point is simplicity is elegance, elegance is simplicity. When I started my PhD, I started doing a lot of reading, and I was reading about this theory called complexity theory, which basically talks about, some systems are so complex you can't predict them. They're just too complicated. And I think pain is one of those systems that it's so complex. But within a complex system, there are some simple rules that can be followed that permeate all contexts. And for me, listening to people and helping them get moving, no matter what area of practice you're in, makes sense, and you can't go wrong with that. So that was one of my first big lessons. So when I'm faced with a complex patient, instead of trying to create a complex solution, I instead try to go back to the basics and try to generate a simple solution, which always involves listening and trying to help people move more. So simplicity is great, everyone can agree with that, but are simple things actually powerful? And simple things can be powerful. And as I was reading more in my PhD, I encountered this idea about placebo effects. And I'm sure lots of you know about placebo effects, but they're basically inert treatments that seem to lead to a positive response. So you can have a positive expectation about a treatment, and that could lead to a favorable outcome. And there's lots of research now that describes the physiology of the placebo effect. And now people are talking more about the clinical application, which is really about therapeutic relationship and how therapeutic relationship can modulate pain like a rheostat. So there's very good evidence now to show that a simple thing like listening can have a physiological and anatomical effect. And this is just a picture of some researchers have basically mapped out the anatomy in the brain of the therapeutic relationship, both in healthcare providers and patients. So simple things can have a powerful effect. So the other thing is, yes, simple things can be powerful. There's elegance and simplicity, but can they be lasting? And I believe simple things can be very lasting. And I'd like to talk a little bit about pain catastrophizing. And so this is something else that interests me when I started studying my PhD. And basically, pain catastrophizing is negative thoughts, worrying about pain, that ends up not being very helpful for recovery. And it's been one of the most powerful predictors of poor recovery in musculoskeletal conditions. And so behind this catastrophizing idea is this communal coping model, which basically states that people catastrophize because they're looking for help. And I think we all know this. Our patients come in and say, my healthcare provider doesn't have time for me. My friends don't understand. I don't want to be a burden to my family. And that's a lot of suffering to keep cooped up inside. And so that usually manifests as pain catastrophizing. And probably the best thing a physio can do for a patient who has pain catastrophizing is take your pen and your clipboard, put it down, scooch to the edge of your chair, and just listen. And so again, if you think about all the times your patients tell you how wonderful you are, it's often related to their appreciation that you took the time to listen to them. So I think small things like listening can have a lasting impact as well. So back when I was green, I had no idea Ted's advice would be so impactful. And as a physical therapist who is interested in complex pain, listening and helping people move are the things that I do every time. And I really try to focus on building that relationship. And I try to pass that advice on as much as I can, so I'm really happy to be able to pass it on to you. And I think if physios as a profession, if we really focus on the things that we're really great at, which is, I think, listening and helping people move, we're going to help a lot of people. And will we succeed? Yes, we will indeed. 98.75% guaranteed. Thank you.
Thank you very much, Dr. Bostick. I would now like to introduce our third speaker, Gloria Gilbert. She is a graduate of the first Bachelor in Physiotherapy program at McGill University in 1967 and opened the first private physiotherapist-owned clinic in London, Ontario in 1982. The clinic attracted a large cohort of people with chronic pain syndrome, and therefore Gloria's work over the last 30 years has been to acquire the knowledge and develop the programming to enable these people to obtain a more functional lifestyle. Gloria earned a master's in physiotherapy degree from Western Ontario in 2002 and has been an executive member of the multidisciplinary health professional organization, the Canadian Academy of Pain Management, since 2007. She is credentialed as a fellow of both the Canadian and American Academies of Pain Management and was honored with a Life Membership Award by CPA in 2011. Let us please give her a warm welcome.
I feel like we're all on the same page here, which is wonderful. Between listening to Jackie earlier today and now listening to Jeff, and also to Alice, that physios are good listeners and we're good people, and we have to do a little bit more about that. So let me just elaborate a little bit. You can tell that I'm older than most of you in the room. In fact, I'm probably almost your grandmother, definitely your mother. And the fact that I'm still so excited about being a physiotherapist is definitely a good sign. It's a great profession. So even when I worked in and this was the time when you could get jobs in hospitals and rehab centers, which would be nice if everybody could start off that way. But even when I worked in adult outpatients at Victoria Hospital in London, I was always the therapist who was interested in the patients behind the curtain. You know, everybody wanted to work with the guys in the gym. Now, I don't know if that's still the typical scenario, but the guys behind the curtain usually wanted to talk, or they were more involved, or we couldn't just quickly do so-and-so's exercises. You know, we had to listen a little bit. So I must admit that early on, and we're talking 79 to 82 when I worked at Victoria, I started creating sort of education programs because there was something missing in just being able to provide treatment versus really getting a patient to understand what was going on. So remember, this is long before we now have a pain science division, and where this was no evidence, no guidelines, no nothing. And when I opened a private practice in '82, the main goal was because I needed to spend more time with people. And when you work in a hospital at that time, you really did not have enough time to speak with people. But as our moderator mentioned, it quickly became a place where people who had had trauma, usually trauma, were not getting any help. This is in Ontario before any auto insurance legislation, before any real understanding of what rehab for pain patients was, etc. So very quickly, the people that were attracted to the clinic were those that, quotes, were not getting better. So right away, I was faced with people who were sometimes 2, 3, 4 longer post-trauma, and some people with medical conditions that were painful, but were not really making improvement. So the way that we didn't have these meetings nowadays. So for years, I was the lone physiotherapist who attended the International Association for the Study of Pain meetings, Canadian Pain Society meetings, and I can tell you that over the years there was an evolution in who's going to win, the psychologists or the physical medicine people. And over time, though, we realized, of course, that a multidisciplinary approach to pain is really what's necessary. So it's really exciting to see what's happening now. But for some of us who started off, we were really working in really a wasteland. Okay. So because I've always been concerned about the people who are not getting better, I guess I have to go to my first slide. No, that's my second slide. That's my second one. Okay. So when somebody comes to see me, I usually have to ask myself, why am I seeing this person? I mean, they've already had an injury a few years ago. What is still going on? They don't seem, like Jeff was saying, I mean, they don't have all those buzzwords. They're not psychologically overwhelmed. They like their job. They like their family. They want to get back to work. So why are they still here? And that was the premise of starting to listen a little differently. And I would agree with Jeff that listening is the most critical thing that we do. So if we just go back to what the word pain means, and I'm not giving a lecture on pain, but just to remind us that pain is just a sensation that says that something is wrong or something is going on that doesn't feel right. And it has emotional, and it has physical, and it has all sorts of other consequences. So as a physiotherapist, after I talk about this word, I never use this word again, because if I'm talking to a patient about their pain, I don't really know what they're talking about. I have to describe it, or they have to describe it, and we have to figure out what's the pathway to help them get better. So I start with this definition. I explain to people, asking them, so if you had to tell me what the word pain means, what does it mean? And usually answers are somewhat functional. It means that I can't work, it means this, it means that I have a headache all the time, until you start zeroing in on that. So certainly this whole idea of pain education has really been an integral part of what I've done, or pain management. But now you really think in terms of, is it just pain, or is there something else going on as well? Because the guy that's showing up in the clinic 3 years post-trauma, who has a good job to go back to and has tried several return-to-work programs and it hasn't worked, it's not the exercise. It's not that they're not trying hard. Perhaps there's something going on. And so I started to observe people. I mean, I've always been a good observer, but you observe more carefully, and you watch them in the waiting room. I'm always peeking out and seeing sometimes people are hanging on to furniture a little bit. Sometimes people arrive wearing ball caps, sometimes with sunglasses on. And my aha moment came. I mean, I've always been suspicious there's something else going on, but my aha moment came years ago when I was listening to Dr. William Padula speak, who's an optometrist, who was speaking at a big rehab conference at Parkwood on stroke rehab. And the aha moment was, well, yes, of course, there must be something going on with the visual system, because why else? Like, we've negated all the other things. And if we think about vision, it becomes center of gravity, it becomes memory, it becomes concentration, spatial awareness. People very often, you know, who are trying hard to remember their exercises, don't remember their exercises, and you give them sheets of paper and you say, follow this, and sometimes they just can't follow those directions. So I started investigating the visual system more, and Dr. Padula is a founding member of the Neuro-Optometric Rehabilitation Association, NORA. Okay, and I would suggest that it's a good resource to go into NORA. In the States, I would suggest that we're probably a little bit ahead about recognizing possible post-trauma effects of vision issues. Not just the sports people, not just children with reading disabilities or learning disabilities. So the NORA gives you a checklist. And as a physiotherapist, I started using the checklist just to see, again, looking at other symptoms that are going on. This is half the NORA. So it's called a Rehabilitation Professionals Checklist. And if you check off enough of those boxes, which is really one or more, the diagnosis becomes one suspicious of post-trauma vision syndrome. And this is the other half of the chart. And if you check off more than one of those, it's the visual midline shift syndrome. Now, those of us, I was listening to Jackie this morning, and many of us have done vestibular courses, oculomotor courses, etc. I think we're sort of at a stage where you got to put all the little pieces together. You know, it's not clear-cut exactly what's going on. So this is a questionnaire that I use that would at least start steering me into another direction. The other thing that I must admit that I use is to do, it's not the whole scan, but to look at the TMJ more carefully. I think there's a myth that the TMJ is somewhat innocuous, especially when you get into chronic post-traumatic, persistent post-traumatic problems. We're trying to change the idea of chronic sounds like, remember, chronic pain is not a diagnosis, it's a symptom. All right, so it's a symptom. So don't diagnose someone with chronic pain. Say they may have chronic pain because they have a back problem or chronic pain because they have a headache, but it is not a standalone diagnosis. And unfortunately, it's still used that way. It's still generically used as, quotes, they have chronic pain. And of course, many of the people that I saw were already labeled. You have chronic pain, you got to learn to cope with it, get back to work hard, etc., etc. You're looking at something like trauma, and I'm not saying it's the only area that you would look at, but if you look at trauma, you have to say what else could have happened at the time of the accident, whatever it was, or the fall, right? Somebody hurt their neck or their back or their shoulder, but maybe they suffered a concussion at the same time. Maybe they injured their jaw at the same time. If you have enough of a blow, you will have these types of problems. So there's a great overlap between what goes on. Now, certainly as a therapist, I can't diagnose someone with a concussion, but I can steer them on the right way by doing some intake. So besides the rehab checklist and besides the TMJ questionnaire, I want to remind you that you have some tools at your disposal that you can start looking at things differently. You have a dynamic gait index. That's not used just for old people. You know, you have balance tests that you can use. You can do a quick balance vision check by talking to someone and saying, stand on one foot, stand on the other foot, open your eyes, close your eyes. You can get a little eye chart and just, you know, get an idea of what they can see and what they can't. And so the diagnosis becomes important, and it's usually done by an optometrist or an ophthalmologist. But then, of course, we're faced with the rehabilitation. So I'm going to get back to this word called pain management, and I told you I never use the word pain, because right away now it's symptom management. I may have an aching feeling or a sharp feeling in my neck over the course of the day, and how do I manage that versus my chronic back pain where I have to swim 3 times a week and I use my TENS unit personally, I do. So I'm following a program 24/7. But what if you have someone who has a concussion and or another reason for their symptoms as well as the pain problem? Well, they too need a symptom management program. Maybe they have to avoid crowds. They have to avoid areas that have a lot of light, a lot of noise, a lot of light, a lot of distraction, so that, and they may not realize what they're doing until you start asking some questions. So the question I now ask the guy that comes in 3 years post-trauma is, do you have problems when you walk into a busy store? How does that make you feel? When you walk into Walmart or Costco, how does that make you feel? Are you anxious? Do you have any problems driving? And we have to realize that that's a whole other area that someone can pick up as a research topic, is driver's anxiety. Is it really driver's anxiety, or is it spatial awareness? Maybe I can't see the edges of where the cars are or are moving fast enough. I can't really tell how fast they're moving. And then if my neck hurts as well, then that's an added problem. And one of the key questions I asked is, are you reading as much as you did before the accident? And they look at me and so say, well, physiotherapists don't usually ask that question. But if you're not reading it, and not that everybody reads as much as we do, but nonetheless reading or sitting behind a computer or watching television, remember there's a lot of movement. Everything is movement, movement, movement. And very often the eye problem, the visual problems become blurriness and fuzziness, and the letters move up and down, and the sentences don't seem to go together. And we have to start asking those types of questions. So that's my message, is to really say to yourself, when someone is not improving, I'm all for Greg saying you must listen very carefully, but the listening may also need some specific questions about their functional day-to-day and make that integrated into the rehab system. The challenge for us, there's a lot of students and a lot of young people in this room, so if you want some research ideas, speak to me. I think I have a whole bunch of research ideas that I'm not going to be doing, but we still have to answer that. Because we do need evidence-based, we need guidelines, we need to help people start. And sometimes when a patient with a persistent pain problem walks in, we really don't know where to start. So we really have to learn where to start. So final note is to remember that person with persistent pain started off as an acutely injured person. All right, for the most part I'm talking about trauma. So looking at, and it didn't come, again, I hope we've gone past that theory of people not coping well or labeling them as psychologically distressed, not to suggest that there aren't some who are. But generally, I would think that most people are still trying hard to get better. So we have to be careful not to label people and say, if that person started off, even if I'm seeing them 3 years post-trauma, I could have been seeing them day 1 post-trauma, or maybe a week or 2 post-trauma. What signs and symptoms would I be able to pick up? Now that we're starting to look at red flags, yellow flags for pain is one issue, but the post-concussion issue is another one, and looking at, this idea of what exactly happened with the mechanism of injury. Maybe you didn't hit your head, but maybe you really got shook up, or maybe for a moment you really weren't sure where you were. That could all mean that they've had some type of brain trauma, and we're not very good at diagnosing it just yet. So I would encourage you to watch your acutely injured patients very carefully and make sure that symptoms resolve before you say they're okay, go back to work. Jackie was talking about sports guidelines and return to play. Well, we're going to have the same thing with return to work. It's the same basic issues. We may not realize that maybe it's not just the physical dimension of the work, but maybe there are other issues affecting somebody being able to return to work. Okay? So call me if you need some ideas, all right? Because we need a lot of evidence-based in this area. Thank you very much. Okay.
Thank you very much, Gloria. So we will be having a question and sort of discussion period very soon, but I am excited to announce our last speaker too. So we have Dr. Vanina Dalbello Haas. She is the Assistant Dean of the Physiotherapy Program at McMaster University. She completed her physio degree at the University of Toronto and her PhD at Cleveland State University. Vanina has worked in academic settings and practiced physiotherapy in the United States, Ontario, and Saskatchewan. So let us please welcome her up to the podium.
You'll be happy to know I'm not going to sing, but we'll just wait a bit. Okay. All right, so I'm actually going to start my TED type-like talk by asking some questions. So there is a reason for the song. How many of you have ever dreamed of winning the lottery? Right, so, after a particularly trying workday that starts and ends with a very long and exhausting commute, this is my favorite place to dream about winning the lottery. On a beach, the warm sun rays touching your body. I'm staring out at the deep blue sea, and I've got a mojito in my hand, and I think, gee, if only I could win the lottery. So now here's a second question. And I want you to think about this. What would you actually do if you won the lottery? If you won $1 million, or $10 million, or $50 million, what do you think you would do with that money? So during the next 6-7 minutes or so, I'd like you to think about these questions. How much money does one need to nudge change? How much money does one need to make big things happen? How much money does one really need to make a difference? Is it $50 million? Is it $10 million? Is it $1 million? So I'm the eldest daughter of immigrant parents who made their way to Canada after World War II. They were looking for a better life, and they were looking to support their family that they left behind. At the age of 18, my dad crossed the Atlantic by boat. And after 8 very long days and 8 very long nights, he finally arrived here at Pier 21 in Halifax. And I'll put a plug in for Pier 21. If you haven't been, you should go. It's a fabulous place. So with his pockets empty, his food supply low, not speaking or understanding a single word of English, no family or friends to guide him, he was actually hustled from Pier 21 onto a train. And that train was going to Winnipeg. And that's where the Canadian government of the time told him that's where the jobs would be. Well, there were no jobs in Winnipeg. During my childhood and teenage years, I actually didn't realize my family was in a lower socioeconomic position. As far as I was concerned, I had everything I needed, right from the homemade cake, birthday cake with the burnt edges my mother used to make, and the green dresses or the matching sister dresses that we always had to wear. And green was my mother's favorite color, and that's why I actually hate green to this day. However, even though I didn't realize I was missing things, I did watch, and I did see, and I did hear my parents confront racism. Why? Because they weren't Anglo-Saxon. They didn't communicate in English. I did watch, and I did see, and I did hear my parents be marginalized and disadvantaged because they didn't have the social capital. They didn't have the cultural capital. They didn't know how to navigate the many, many, many systems that one needs to be able to navigate on a daily, on a weekly, on a monthly, or a yearly basis. So those memories are really etched in my mind. But I also watched and I saw and I heard my parents make the most of what they had, which wasn't very much for the most of my childhood and teenage years. They made the most of their human capital, regardless of not having social and cultural capital. They supported those in need, and they gave to make things better for others. So all the while, they were teaching me important, incremental life lessons. And in particular, they were teaching me that one doesn't always need much, and one doesn't always need large sums of money to make a difference or to really affect change. So, like many, my personal and professional paths are strongly influenced by the important incremental life lessons of my early days. My interests, while varied, often return to what I value greatly. As physiotherapists and as a profession, we have a gifted opportunity to make change happen, and we have a gifted opportunity to make big things happen. Let's just think about what we as physiotherapists are trained to do. What we as physiotherapists can offer in terms of our knowledge, skills, and attitudes. Are we not in a unique position to be at the forefront of changing the systems to address disparities, inequities, inequalities related to availability, access, and affordability of services? So in 2013, like-minded colleagues and myself received $5,000 through the Physiotherapy Foundation of Canada. In the research and grant worlds, this is considered a very small amount of money, and some might even say minuscule, why even bother? Definitely $5,000 is nowhere near Dr. Mindy Levin's amount of funding, but it was $5,000. This small amount of money was directed to the Mac Hope Clinic, which is a community-based clinic located in the downtown Hamilton YMCA. It's an alternative delivery model for rehabilitation services. It aims to provide the right care at the right time in the right location to low-income Hamiltonians who would otherwise have no access to rehabilitation services. So let me just show you a little video clip of what we've accomplished with our small PFC grant.
What brought me to the Mac to Hope Clinic was I found out of it through career links, and because I pinched my nerve, and I was trying to find, I knew I needed physio, but I couldn't afford it at this time, basically, not right now in life. So it interested me. So I came here, called them, made an appointment, and came, and everything was just so positive from there, you know? The help I got and retrieved, and they showed me what I could do also to help more.
I had an assessment at the Good Shepherd building on Locke Street, and was advised, well, maybe I should come here and have some treatment, and because I want to keep mobile, and I don't want a hip surgery, and I want to keep on running my 5Ks. So that's what brought me here. I love the people here. I feel like a human being treated with respect. It's wonderful.
I think I have to, oops, go back. Oh, sorry, don't mess with the equipment, right? Thank you. All right, so what else have we been able to accomplish, or what else has been materialized through our $5,000 minuscule PFC grant? We've provided rehabilitation services for 136 individuals who otherwise would be unable to access or afford rehabilitation care. We've provided physiotherapy and occupational therapy students with opportunities to interact with individuals they might not have ever had the chance to interact with. They've been provided with the opportunities to learn important life lessons and professional lessons about the issues around disparity and inequality, around access issues, affordability and availability issues. We've received press, both internally and externally, further boosting our referrals to the clinic. But more importantly, we've highlighted the healthcare and service disparities within our own community and the great need for rehabilitation services. We've created a really large beehive of buzz around our school, among the student body, among the staff and faculty, among the alumni, resulting in concerted fundraising efforts going towards the Mac Hope Clinic initiative. So actually that $5,000 has just recently been transferred into an additional $10,000. Our students picked our clinic as their charity of choice for this year's charity ball, and they raised $10,000 over. So kudos to them. And really, I could go on, but I was told I only have 7 minutes. But that's where we're at right now. Nope. Sorry, stop messing with the slide, right? Okay. Oh, not done. Thanks for the clap, but not done yet. So let's go back to my original question. So how many of you have dreamed of winning the lottery? Hands up. Okay, so, and I'm going to ask you, what would you do with your winnings? How many of you thought to yourselves, I'd make a donation? Right? Yeah. So we all think that we need to have big winnings to make a donation. Well, you don't need to win the lottery to make change, and you don't need to win the lottery to make big things happen. And you definitely don't need to win the lottery to make a donation. Right now, you can make change happen, and you can make big things happen. Right now, you could make impact on physiotherapy research, which in turn will positively affect the health of Canadians. Right now, you can turn visions like ours into reality, and right now you can make a difference. Now you can clap. So before I get off the stage, you can just play the music. I do want to thank the PFC for their support, and actually they invited me to present on behalf of the PFC to show you that any little bit helps, and it actually makes great change. I'd also like to thank the Congress Education Committee for the opportunity to participate in today's session. And last, I'd like to thank my faculty colleagues and all those involved in Matt Cope Clinic, and for all the life lessons I've learned. Thank you.
Thank you very much, Dr. Dalbello Haas. So that concludes now the speaker portion of this session. So we do have maybe around 5 minutes for some questions, if there are some questions or comments anybody would like to share. But I would like to mention that as a student, it was really wonderful hearing all of your presentations and receiving the education and motivation from all of the different talks. So thank you. So if anyone does have a question, I will bring over the microphone, and then you can give your question into the microphone and someone will answer it for you. Sure, exactly. Wonderful. So our speakers will come up if they would like to and sit on these comfy chairs. I hear talking of that. So good, perfect.
I don't really have a question, but I'm a physiotherapist in the military, and I just really needed to say thank you to Alice, because for the full 7 minutes you spoke, I cried. Because I have so many Kevins and so many patients that, and it's the same in the civilian system, that get lost every day and that get missed. And you just really pushed me to continue to fight for those people that don't have a voice always. And within the military and outside of the military, thank you, Alice, so much.
Thank you. Does anybody else have any comments or questions? Yeah.
This is actually a question for Alice and Jeff as well. I'm really heartened to see that, that we're looking at health from broader dimensions these days, and in particular looking at mental health and other elements of wellness. And I'm really, really inspired by the work that both of you are doing. And I was a little bit curious about where to find more information about how to potentially participate in, in some elements of the research that you're doing.
Yes, certainly. For our institute, we have a very robust website, www.cimvhr.ca. And we do welcome research from anyone, and we do research in all areas. I'm crying, Sarah, thank you. Mental health, physical health, novel technologies, occupational health, gender differences, so everything, all areas. And we welcome research from all our partner universities. There's 37 of them. Every university that has a physio school is part of us. So yeah, please just connect with us.
Yeah, we're doing some work in the private sector on PTSD, and so I'm really intrigued by the work you're doing.
Yeah, well, and One more thing, it's a two-way street. The military physios have actually taken the mantle of incorporating CBT into their practice. And it's a two-way street. We also communicate the great ideas from the military back to the civilian healthcare community, because a lot of medical and health advances come out of war, right? So yeah, it's really incredible. So really happy to anyone, happy to have you. I'll let Jeff talk.
Thank you for your comment. I just will do a little plug for the Division Knowledge Management Committee. So I'm the co-chair of that committee. And so the job of the Division Knowledge Management Committees within all the divisions is to really help connect clinicians and researchers together. So if you have an area of interest in a particular practice area, so if it's pain, you would contact me and I would help you connect. So divisions are a great resource as well.
Thank you very much. Does anyone else have any comments or questions? Okay, no problem. So on behalf of the Canadian Physiotherapy Association, I would just like to thank our presenters very much for taking the time to be here today and to provide us with such wonderful messages and wonderful education. Okay, and I'd also love to thank all of the audience members for being so wonderful and for participating today in the session. I think you've all received the green cards when you came in, so if you wouldn't mind filling that out, the Canadian Physiotherapy Association really appreciates having the feedback for the following years. Okay, and also there will be the audio recording for this session available after Congress wraps up. So if you are interested in hearing it again or providing this to someone you care about or someone who you think would benefit from the knowledge shared here, then please do listen to that again. Okay, thank you so much.